This is Health Assessment of Children from Essentials of Pediatric Nursing by Kyle and Carmen. So the components of your health assessment, you're going to get a good health history by interviewing the parent and child, but along with that health history, you're looking at the interaction between the parent and child. Do they interact appropriately? They seem like they're well bonded? You're going to ask about the developmental assessment for the child, emotional as well as physical and cognitive and social. And then you're going to get your physical assessment. So as you're doing that interview, you're going to use therapeutic communication. So this is your active listening, using open-ended questions instead of yes and no. Make sure you're in a comfortable room that's not going to be interrupted. But when you're dealing with pediatrics, you also want to make sure you have things for the child to do. They're going to get bored. A toddler's going to climb all over the parent. An older kid's going to interrupt. So make sure you've got age-appropriate toys or activities for them. And then do your best to establish a good rapport with the family and with the child. So you can see this kid's got toys there that he's interested in. So he can answer questions, but when he's not involved, he's not being bored and interrupting. So when you get that health history, we want to ask about their prenatal experience. So ask the family, were there any issues during pregnancy or during birth? It's surprising the things that people don't connect together. They don't realize that something that happened at birth could have effects now. Ask if there's been any developmental concerns. We want to know about prior illnesses, accidents, and injuries, any hospitalizations or operations. We want to know about their diet, partly for cultural reasons, to make sure we're offering them what they do eat, but also that can make a difference in health. Like toddlers who drink tons of milk tend to be anemic. So we want to know for those reasons as well. Allergies. Ask what their allergies are, but also ask what happened. Sometimes people use the term allergy when really it just upset their stomach. We're going to try to not use medications that upset their stomach, but if that's the best medication, we can use it. If they had an anaphylactic reaction, we cannot use it. So we need to know what the reaction was. Find out about their immunization status. If they are immune to an illness, then we can take it off the list. That's not what they have. Find out what over-the-counter or prescription medicines they're already on. And if we have a teen female, find out about menstrual history. So physical considerations, as you make this plan of getting your assessment based on their developmental age. So for infants and toddlers, they probably want to stay on their caretaker's lap. Toddlers, approach them slowly. Don't come at them too fast and too aggressively. Preschoolers and school-age children, let them touch things and look at them before you use them. Teens, we got to give them some privacy, and some of the questions we want to ask, we need to ask in private. They're not going to give us honest answers if the parent's there. And then direct the conversation to the caregiver for young children, but for older children and teens, make sure that they're part of the conversation as well. And here's a child getting to touch an otoscope as he's sitting on his mother's lap, making it far less scary. So developmental considerations, you want to do your physical exam going from least traumatic to most traumatic. And I would say for most kids, the most traumatic is the blood pressure cuff, because they don't know, it starts squeezing. They don't know how hard it's going to squeeze, how painful it's going to be. At Valley Children's, they use tympanic thermometers. Those are also quite scary because the child can't see them. So let them see it and tell them what you're going to do before you start putting it in the ear. Let the family stay, but there are some kids, particularly toddlers and a few preschoolers, who when we get near them, they cry. And for some families, that's upsetting and they would rather step out. So don't force them to stay, but allow them to if they want. And there's a good table on that in the book. So here's a girl that preschool age that's getting to play with stuff. So Your physical assessment, you're going to look at their general appearance, get their vital signs, measure height, weight, head circumference, body mass index, BMI, and their activity level. A kid who's too sick to play is pretty sick, so that's a good barometer of measuring how sick they are. Orientation, mood, pain assessment. And as you do the examination, you're looking at head, neck, eyes, ears, nose, throat, mouth, skin, the thorax or chest, lungs, breast, heart, peripheral perfusion. Let me just say, if you're in my clinical group, every child, every assessment, I want capillary refill on all 4 extremities, peripheral pulses on all 4 extremities, abdomen, musculoskeletal system, neurologic, genitalia. This is from the book, The Normal Range for Heart Rate and Respiratory Rate based on age. At Valley Children's, you'll see it's broken down a little more. Infant is birth to 1, where the age ranges they use at Valley Children's, they have birth to 3 months, 3 to 6 months, so they narrow the ages a little more. But they're really the same ballpark. When you do your respiratory assessment, of course, you're going to listen for the rate, and you're going to look for respiratory effort, but you've got to describe it in more detail than that. Do they have retractions, which is using accessory muscles? And there's a big difference between mild subcostal, they're using just some muscles here, and severe intercostal. So they're using those intercostal muscles. It looks like their ribs pop out with every breath. With infants, they're obligatory nose breathers for the first 6 months or so of life. So you'll see nasal flaring and head bobbing if they're having trouble breathing. When you listen, don't just say they have wheezes. Are they inspiratory? Are they expiratory? Are they just occasional, or are they every breath? Stridor you hear out loud. It's swelling in the throat and you hear it audibly. You don't need a stethoscope for it. Crackles. Cough. A dry hacking cough goes with asthma. A wet moist cough goes with RSV. Productive, that's really hard to say on a baby or a toddler, because if it is productive, they swallow it. They don't spit it out for you to see it. Grading murmurs. Take advantage of listening to murmurs. You'll get a chance at Valley Children's. So listen to some murmurs. You'll see in the chart they grade them between 1 and 6. I don't expect you to grade them, but just so you know what that is. If you do hear a murmur, notice where it is. Are you over one of the valves when you hear it? Or, where do you hear it at? And when do you hear it? Systolic murmur is going to be between your lub dub. A diastolic is after that lub dub. Okay. There's a good site, the Stanford site. It's got multiple pages. You can scroll through the different defects and listen to the murmurs that are associated with them. If you have a kid on a monitor, kids pull the leads off, so put them back on. I've had students be afraid to do that. Just stick them back on. Don't worry. It doesn't have to be in the exact right spot, because they'll pull it off again. A lot of times you're going to see them in weird spots because it's where they don't pull them off. And if you see a really weird EKG, don't try and diagnose something. It's probably the leads are in a weird place. So look at the leads before you think that there's something going on with that EKG. When you do blood pressure, we can do it on upper or lower extremity, upper or lower portion of that. Of course, the closer you are to the heart, the better. So that brachial artery is your best. But to get a good blood pressure on that on a baby, you got to hold the arm still. They're going to start screaming and fighting. It's really hard to get. And if you do get it, it's going to be elevated because they're screaming. So you're going to see they do a lot more legs and lower legs because they can get it without upsetting the child. If you do it on a different extremity or different part, you got to think about where the artery is. If you're on the lower extremity, the popliteal artery is behind the knee. If you're on the lowest part of the leg, that posttibial artery is right behind the ankle. So, growth and development, we're asking you to plot every child at the hospital on a growth chart, and what we want is weight for age. There are different growth charts, especially your trisomy 21, Down syndrome, they tend to grow differently, so make sure you're using the right growth chart. There's male and female, there's up to 36 months, and then there's up to 18 years, so you got to make sure you're looking at the right thing. And again, what we really want is age for weight. There's also for height and for head circumference and different things, so make sure you're using what's being asked for. And here's a picture of growth charts. And if you haven't done this, the ages are along the bottom here, and the weight is going up here, and the length is going up here, and you find the age and the weight and wherever they match, and you follow this out, and that's their percentile. Whoops, no, it's littler print. It's right there. That's the 50th. So skin, kids show a lot of stuff in their skin. So you're going to comment on what you see. Pallor, which means pale. So they're not, in a light-skinned person, they're not pink. In a dark-skinned child, they have kind of an ashy gray look. Pallor means they're not circulating to the surface. And that can happen with a fever or shock or syncope, dizziness that made your blood pressure drop. Anxiety can do that. The other thing that can do it is anemia. So every hemoglobin is carrying oxygen, you just don't have enough hemoglobin to make it pink. Cyanosis means you have hemoglobin not carrying oxygen. So this is where you're going to see a low saturation. And that cyanosis is kind of a bluish color, so comment on, is it peripheral or is it central? The head, face, trunk. And again, those are two different things. Pallor comes from not circulating oxygenated blood out to the skin, or just not having enough oxygen in the blood because of anemia, where cyanosis means you have hemoglobin not carrying oxygen. So your oxygen saturation, the percent of hemoglobin carrying oxygen, is low. Jaundice, this is our yellow tint. Remember, it starts on the head to the trunk out to the extremities. So if you're seeing it on the hands and feet, that's a bad sign. Yellowing, some kids who eat a lot of carrot or yellow-orange vegetables will actually look kind of yellow or kind of orange. That is not a problem. So we need to make sure we're not calling them jaundice. Ruddy is being red. This can go with, if you blush, you turn red. Can go with fever, hyperthermia, alcohol ingestion, right? You get that red nose if you've been drinking. Lack of color. This is somebody who's got albinism. If they're born with it, it's albinism. If it's acquired, it's vitiligo. And when you're reporting skin, you're going to report the color. If you see something on there, its color, shape, and the number. Is it just one thing or are there multiple? Where's it at? The extent of any lesions, and then describe them. Scaly, flaky, flat, or raised. Induration is the word for raised. A vesicle has fluid in it. Crusted means it's probably had fluid in it, but now it's got like a little scab on there. Weeping, it's draining. It's not getting a dry scab. Is it itchy? Is it macular versus a papule? And if you remember, a papule pops up where a macule is flat, but they're both usually less than a centimeter. You need to know the right words, so when you talk to the doctor, you're using the right words, but you also need to use words that kid will understand. So, do you have an itchy red rash? And then you call and say they have, a flat, erythematic, pruritic rash. So, use your right words, and change those words depending on who you're talking to.